Really interesting parallels between bipolar and autism as well, and don't quote me on this because sometimes my memory doesn't serve me 100%, but I remember when I worked at Leonard Cheshire, I was quite shocked when I found out that one of the clients I had who had severe autism, how easy it was and how quick it was that they managed to get a care package signed up for, I think it was about £250,000 a year for this person. They were displaying quite violent behaviour, and they was to basically have a care worker, 4 or 5 care workers basically round them 24/7. And you think if they'd actually had that early intervention to be able to learn how to manage a condition early on, then that person's life could have been completely different. And I know one of my colleagues, I'm not an expert in autism at all, but she had actually done quite a lot of training and had delivered care packages to people. She's saying, look, this person could have a weighted coat, they could be out with maybe 2 care workers, they could be going around in the community. So there's enormous costs in there in the system, which is basically just trying to keep people safe in that immediate moment. And if that person is able to give the skills to be able to manage a condition and those conditions around them, it can make such a massive difference in their lives and other people. And people can have an opportunity to contribute as well, which is so important. So lots of parallels there. And there's one final anecdote. I think what we could all agree on is better data capture in terms of the conditions that are meaning people are being hospitalised. We've certainly struggled. There's a big opportunity at the moment with the reform of the Mental Health Act, where there's a big focus in terms of reducing admissions, and that's fantastic. They're really pleased that the government's looking into that. But unless they actually understand what's bringing people to hospital in the first place and what the reason why people are becoming unwell, you can't then have those targeted interventions to be able to focus on the preventions, because prevention for someone with autism is going to be very different for someone with bipolar, even though there is obviously going to be an overlap with the condition. So I think we'd all agree on specialist care and treatment as early as possible. So I'm going to open it to the floor now. Questions? I've had wonderful questions. Brilliant. So, lady here. Go on.
Hi, just a question maybe for Dr. Lizzie. We work in the field of diet, and I know that there is really quite strong evidence now that diet has a positive impact on depression. I was curious about the impact in bipolar, which obviously has some depressive elements, and I'm not sure if there's any research. I wondered if you knew of anything, and also, are you doing anything in that area, and would you like to have a conversation about that?
It's very interesting to have a conversation about this, and Andrew might well know the research and evidence base about diet and bipolar better than I do. But I guess what I would say is we do spend in our course quite a lot of time talking about routine, the importance of routine and regulating your nutrition as well as your sleep, and people do forget to eat, particularly when they're hypomanic. They might grab things on the go, and so that is integrated in what we do, but without specific dietitians or people like that on board, I guess. So I think there is definitely things that we could explore there.
And for the other 2 ladies, I'm sorry, I forget the name of your project, but the autism. I mean, you didn't mention diet in any of that either. I mean, is that something that you look at all?
Yeah, well, obviously part of the care package is largely focused on the same routine around the therapeutic approach and making sure that everything is healthy and balanced, mental health and physical health. So that is a large focus on the day-to-day, certainly for the children in the care system that we support, and then the wider outreach support of helping families access various different options around health.
I mean, obviously autistic kids have a lot of issues around food as well, and what they will and won't eat.
And sensitive diets,
yeah. Thank you.
No, it's very early days in the study, but I know Professor Danny Smith up in Scotland is doing some interesting research on the keto diet and bipolar. So that might get some interesting findings as well. Any other questions? Just want to say where you're from as well. Sorry, I should have.
Hi, my name's Hayley. I'm from Grey Minds Together. I just wanted to ask, in terms of bipolar, my brother's bipolar, and he was only diagnosed in his early 30s. And he suffered significantly with his mental health and was diagnosed as depressive and, like you say, given antidepressants. And I think that delay in diagnosis is massive. And I just wanted to ask, is there any sort of focus on training for the people who are doing the assessments and for, you know, the professionals who are actually sort of seeing the people who are potentially coming in with depression symptoms, but it's bipolar, because that seems to be a big barrier to the actual diagnosis, and that delay in it is the similarity in the symptoms that can be misconstrued as other things. So is the sort of funding and focus on that in order to try and reduce that diagnosis period?
Addy, do you want to answer that? We actually did our very first training session yesterday, didn't we? So it's very apt with both Lizzie and Addy, and Eve actually, so it's, go on, Addy.
I hope I'm loud enough. You know, I've been working in the field of pediatric mood disorders since 2006, and it's a privilege that you've all sat here and listened to Barry and myself, because in 2006 I could empty a lecture theatre before you could say the word boom. There is something quite emotive about a mood disorder, and I had great mentors who said, stay the mile, because in the 1980s it was thought that children couldn't even have depression. The idea that children could be depressed was, you know, it was very, very provocative. So in the 2000s, it was thought that kids could never have bipolar. And when I say kids, I'm talking about under 18s. I'm not talking about 6-year-olds going in for lithium or sodium valproate treatment. I'm talking about teenagers. But you're absolutely right. I think we have to do more to raise awareness, and the things that we are doing, certainly I'm involved in a lot of work with the Royal College of Psychiatrists, through Bipolar UK now. We're trying to raise awareness in a targeted fashion at those working in CAM services. So obviously that's our passion. Because I think that's where the early intervention needs to happen, and I'll bring Lizzie in because I know this is something that's very close to her heart as well. We're also working, I chair the British Association for Psychopharmacology, so this is about training up and skilling up child psychiatrists, GPs and non-medical prescribers on how to prescribe, but also what not to prescribe. So, you know, certain conditions, like there's a very strong family history of bipolar, then if you must start an antidepressant for a young person, how should you do it? How should you monitor for that? Looking for any kind of triggers, etc. But we have a very long way to go, and I think what we need is almost like an advocacy campaign, that kind of lived experience that Eve talks about so eloquently. Sorry, Eve, again, to sort of say, because her last thing, we were at an event yesterday, and her last line was, the diagnosis has enabled me to thrive, not just survive. And I think it's, sorry, Eve, because I keep plagiarizing it, but it's such a beautiful line. And I think that we need, you know, perhaps yourself, Eve, others to speak out for the need for it. I'd love to run more training events, and because I'm so passionate, I hassled Camilla here, the wonderful Camilla from Bipolar UK. We just run our first ever masterclass for health professionals yesterday in London with Bipolar UK. So Lizzie was there, Barry and I, and of course Eve. We would want to do more of this, but there is of course a financial implication. Perhaps I could bring you in, Lizzie, from a sort of adult
good. I mean, one of the things that we're trialling across Birmingham, but it is completely new, is because early intervention in psychosis has obviously been going many years now, and they have a checklist that you can use in primary care. You know, could this be psychosis? And you can do it, and then if it scores a certain amount, then you pass it on to the early intervention team, and they see you within 2 weeks. But there was no such thing for bipolar. So in Birmingham, across the care pathway now, we've put a mood screen and the psychosis one back to back. And we're going to trial it in our primary care services, so that when a GP or someone in the neighbourhood team sees somebody like your brother, and I'm really sorry to hear about his experience, but that is a common story, that people don't get diagnosed for that long. We still need to be spotting these people, because these people are in our primary care services now, that we can actually use that scale, and they can refer very quickly, hopefully, to secondary care service for a really thorough intervention. In terms of like clinical psychology and IAP, so the Healthy Minds primary care services, they see lots of people with depression. And I do quite a lot of training for these kind of psychological therapies groups. And I always ask the question at the beginning, when you've got someone that's depressed in front of you, do you ask about energy, sleep, hypomania? And everyone goes a bit silent, and it's like, tumbleweed moment. And so actually we are constantly, when we do these training sessions for health professionals, saying, always screen for high mood when you screen for low mood, because if people are saying they're depressed, always ask the opposite. And I think if that's the message everybody can get across, but that's ad hoc training, I think that needs to be across the board really. I'm not quite sure how we get that across the board, but I think that's what needs to be done. We need better training by health professionals, because if 1 in 50 people have it and lots of people are presenting with depression, we're actually missing a huge amount of people who probably have got bipolar, and then they don't get on the right treatment path and they can't self-manage and live their best life.
Yeah, I think there's going to be a phased approach, isn't there? I mean, it's very compelling. We know that specialist treatment is more cost-effective, and it seems like there's a great injustice there that it exists for other conditions but not for bipolar. But at the same time, there's steps that we can take. We know that First Steps in Psychosis services, they pay their way, they're very effective. Making those more bipolar friendly, training the staff up to be aware of bipolar would be a good place to start. We know that our peer support service is a very cost-effective self-management courses. There's no reason why the NHS couldn't be funding those now. A lot of trusts do already. We did a campaign just as a charity and from a charitable foundation, and we found 10,000 people through doing a social media campaign. We found 10,000 people with undiagnosed bipolar who are then going to go on to see their GP about the condition. Even if the NHS itself was not set up as it should be to diagnose those 10,000 people, at least they have the self-knowledge then to be able to start their own journey, perhaps start looking at sleep, perhaps looking at peer support and so forth that they could start to access. So I'm an optimist in terms of what's possible. It's been done for eating disorders at the moment, which is fantastic. It's been done for psychosis services. They've done a lot of progress with depression. So, I mean, it is possible to do these things. The NHS does do it, and it's a matter of time. As Adi said, for the patients he supports, it's not a matter of if, it's a matter of when, and we just want to for it to happen as soon as possible. Any other questions? Gentleman there, just be able to share where you're from as well. That'd be fantastic.
Yeah, hi. So I'm Gary, and I'm from Mental Health in the Workplace and a solution-focused approach. And it's interesting because we've sat through a few talks and they've been amazing, and some of what you're doing is really brilliant. But you all talked about psychological care, but none of you talked about brain-based therapy. Some of you talked about a level of neuroscience, but then didn't look at therapeutic and modern forward-paced therapy, so solution-focused, brain-based therapy, which is now the fastest growing everywhere in the world, but none of our services are offering genuine solution-focused therapies, psychotherapy. It's funny you mentioned Birmingham Children's Hospital 2 or 3 times. I run a school in a therapeutic training centre in Solihull, and Birmingham Children's Hospital have sent and paid for 3 of their psychologists to come and be trained in our methodology, and they use it within that service, except they're the only ones who do it. So we get independent medical people come on and pay for themselves. But none of the services are bringing that. So I'm just wondering, what evidence do you need to start looking at a more modern approach to therapeutic intervention? Because some of the stuff you're using, like CBT, has a response rate of less than 50%. So 50% of people opt out of it, where we know research I've carried out, which has been published, that's not the same in modern day therapy if you use right therapy. So I'm just asking anyone, what do you need to start using a completely more modern approach to helping people get better?
I'll pass on to Lizzie in a second because she'll be able to talk more about the talking phase and Adi as well. I think also the NHS does get a bit bamboozled by the new, and it's always try to be a world leader in chasing the latest therapeutics that are around, and actually just getting the basics right will be fundamental. I mean, a lot of people, psychiatrists, say that actually mental health services have gone backwards for people with bipolar the last 20 years. Something as basic as actually just getting a psychiatrist to diagnose someone and then prescribing lithium, which is that has been around for 70 years probably.
Absolutely.
And that could probably solve about 90% of the problems that people are experiencing with regards to bipolar. Maybe not 90%, but certainly 50% respond well to lithium or thereabouts, and that's a generic treatment. I'm not saying that's what you're advocating for, but the NHS always tries to run over the new and expensive.
Mental
health
the service
right
is
first.
mental health, and only 6% of the budget goes to children and adolescents. Less than 6% of the whole mental health budget. So we've got to find an intervention, because you're all here and working amazingly hard to try and achieve the same goal, getting people better, using stuff which is having quite a high response rate, which is people not responding to the treatment as well as they could. So I'm just wondering what evidence you need to start moving forward.
Lizzie, do you want to talk about that?
I mean, I think fortunately we definitely come from the same place, because you're right, we want people to work, we want people to get better. Fortunately, actually, I would say there's a much less dropout rate of people with bipolar. You saw the numbers in terms of the interventions, because they have been co-created, they are designed specifically for bipolar. So actually 11 out of 13 sessions attended when people are actually quite unwell, I think is very impressive. I don't think it's just us that are great and that makes them come. I think the peer support element, that people are supporting one another, makes them come too. The NHS is a slow-moving beast. NICE guidelines are really slow. Simon, I think you'll know the stats for this, but the investment in research for bipolar disorder is tiny in comparison to schizophrenia, autism. It's just a drop in the ocean. So understandably, the NHS will only commission evidence-based interventions that they know have got randomised controlled trials that work really well, because that's at the point that they can do it. So intervention development, I'm doing compassion focused therapy at the moment. No way that could be rolled out across the whole of bipolar service, because we don't know for sure that it works. We think it probably does, but we don't know for sure. So that takes a long time to get that evidence base built up. And you need funding in research for new interventions for that. So I would say that's, alongside improving our services and actually delivering what we currently know works, which we're definitely not doing, we also need to put money into research with those new, as you call them, modern interventions, to show new things that are going to broaden that spectrum, more different things for different people. But that takes loads of time to develop those interventions and evaluate them properly, so people like NICE will say, yeah, you should be providing that. I don't know whether you've got anything you want to add to that.
I'm just going to, I'm not as optimistic as Simon. I am an optimist. Simon's an internal optimist, and Lizzie is also, optimistic but grounded in reality. I'm not very optimistic about the NHS. I'm sorry, there's been lots of wrong decisions made. It's a shame, because what you're saying is right, but what we need is somebody from the commissioning group to answer that question. It's the ICB, it's the CCGs, not us as clinicians. I have been going to every single body, including NHS England, alongside Barry, to ask for commissioning our service. We save lives, and on average it takes 3 to 9 months for a patient to secure funding from their CCG to come to our service. How is that acceptable? Yeah. But I think the thing about your question is very much around solution-focused treatment. To the best of my knowledge, and I might be slightly out of date, the thing about is that it's also across the age range. There have to be developmental modifications to work with kids. I don't think a lot of work's been done in the field of bipolar with solution focus. Absolutely, we should do more. I was the chief investigator for the only pediatric bipolar disorder psychotherapy trial in the UK. There's been one study to date, and that wasn't a fully powered trial. It was just to see whether it's acceptable and feasible. And we showed that it was acceptable and feasible. Why have we not gone to a fully powered trial? Because there are these huge costs, and the NIHR won't fund research. They won't fund the therapist's time. You have to go to every single CCG to secure that funding. Yeah. And it's impossible. It's impossible to do research in psychotherapies. I really, really want to do it, but very, very challenging. It's great that Lizzie's doing that. I'll leave you with this thing. For every £100 spent on cancer research, £1.20 is spent on schizophrenia research, and 16 pence is spent on bipolar. And I don't even want to tell you how little of that goes on to kids with bipolar.
Yeah. Well, at best 6% of that.
So I just think it's, given the burden that Simon has spoken about, every single one of us has somebody living with mental health issues, probably mood, because they're the most common disorders. How's that acceptable? We all, please go away, please challenge, please spread the message, because that's the only way things will change, not just by educating.
So I'd like to invite you to look at some new research which we conducted. It's out there, research which has been published on solution-focused hypnotherapy, and we did it with Northumbria Police Force very recently, and it's just been published. So if you want to look at the comparison of, it's about general mental health, but it's a start. It's a proper published study, which we've
you don't
done.
Need to convince us. I
No, so it's there, but it's there, and you now have something to cite. It's citable now. So there's at least a movement forward, but we don't see it anywhere. Even in we're trying new things, we never get trialled. We never get asked, bring what you've got to the table. I'm just wondering what we need to do, or anybody in our industry needs to do, to just offer something which might help.
Just find a good trust. I think one of the there needs to be some big questions asked to the community voluntary sector framework and see what it's delivering. I think they're going to do an evaluation soon, but certainly there's a huge investment in the community voluntary sector, and I think we're still seeing admissions going up. There might be some good stuff in there, but there must be some good learning from that. But also looking at IAP services, which is a huge, massive investment from the NHS. Oddly enough, people with bipolar are actually excluded for a long time from IAP services. Interesting studies, about 20% of people using IAP services go on to get a bipolar diagnosis. Oddly enough, you do get anecdotes of GPs who can't get a referral to secondary care to diagnose a patient with bipolar. So what they do is they send them to IAPs in the hope that IAP would flush it out, which is completely bizarre. I mean, presumably just sitting for 45 minutes with a clinical psychiatrist to provide a psychiatric assessment is much more cost effective than 10 sessions of CBT. Something to look at. Though we need to be kind of careful at that, because people with bipolar studies do suggest they do benefit to the same extent as the general public from those services. So actually it should be looking at, as a health economist, we're looking at, would it be better to be diagnosing people with bipolar and doing an assessment, or maybe solutions-based therapy is in comparison to CBT or IAP services. But it's easier for the NHS to commission more of what they got than it is to do something new. That's what they've learned. And they do the same for physical health. That's why physical health is relatively very well funded. It's easier to commission another cycle of chemotherapy for someone, even if it's like 10 times more expensive than specialist treatment for another condition. But any other questions? We're still within 30 minutes. We don't have to all stay here. We've all got lives and families. Any final questions at all? Go on.
Hi, thank you. My name's Lydia. I'm a Deputy Director of Nursing and Quality for an ICB.
Brilliant.
So I'm sure you're all going to be glaring at me in a minute.
Not
so
at all. You're one of the allies. Go on.
I'm a children's nurse by trade, and I'm also a mum to 2 boys, one of which is on the autistic spectrum and has help in school to be in school and EHCP. And my other boys also has challenges with anxiety. So I'm a bit of a mix between professional experience but also an experience as a mum. So what I wanted to share really was thank you for how powerful all of your presentations were, and particularly yours, Eve. It always hits home when you hear somebody's actual lived experience. So thank you so much for sharing that. I found it really powerful. I completely agree with everything you're saying in terms of the funding and the position we're in as an NHS. But I particularly feel it as a mum as well, of 2 children with additional needs. What I wanted to say really is a comment, probably more than a question, and just open it up for yourselves, but it's more about prevention in terms of supporting people earlier, identifying challenges earlier and needs earlier. And I suppose that's where my head's at, and particularly when I think about the population in which I serve, with the highest rates of children in care in our areas, and the challenges that brings, but also the budget constraints and the difficulties where we've not helped people early enough. And when I'm looking at particular investigations into learning from where things have gone wrong, predominantly the thing that comes across for me is, why didn't we recognise this sooner? Why couldn't we support it sooner? And it really prevents that upstream, the need for particularly specialist services for a lot of cases. So I think that's a comment from me. So thank you, though, everybody. It was really helpful.
Thanks. Just to say, we've got a clinical advisory panel, which is a network of doctors, also commissioners, who just have an interest in diagnosis and specialist treatment for bipolar. So if there's anyone in the audience who's interested in joining it, then we're very happy to. But also for commissioners as well, obviously very keen to help. I'm always an optimist in terms of what is possible. The NHS does change, sometimes for the better, sometimes for worse. But I know for ADHD, that was something that was very challenging for a long time, didn't get many services. And then by an accidental fluke, they ended up having loads of people getting referrals to a private sector provider, as I understand it. Massive waiting list, 20,000 people, and now there's a national task force looking at ADHD. And if you can get early intervention, you can make the case for it. Then I think you will be able to see change, because then you see the costs coming down further down the line. So it is possible. Addy, the word of doom. No.
I'm not going to be. I think it's so commendable and brave of you to both admit that you're a commissioner, but thank you for sharing your story as a mum. It's, one's lived experience. I don't mean to be patronising at all, but I can't say it enough. That's the real tug, and that's what we need. I just want to say, sorry, I'm a child psychiatrist, and I still remember my interview for the clinical academic post in child psychiatry in the North East, and I was asked, why do you want to do child psychiatry? And I said, because I want to alter trajectories. Child psychiatry, or CAMS, is early intervention. EIP has made a big name for itself, but what CAMS does is early intervention in everything. That's what we do. But we don't get the investment. We are the Cinderella of Cinderellas. And we have come to this position now where I have patients who are truly manic, teenagers who are being told, well, they're not jumping off a bridge or trying to slit someone's throat, keep them locked. We're so overrun completely, and we're so burnt out, and morale is so low. We need to fundamentally, talk honestly. It was so refreshing to hear you talk honestly, because we just get management speak and gobbledygook. And when I challenge that, I'm going to paraphrase Lizzie, because I won't say what I would say normally, but as Lizzie said politely to me yesterday, we get sent off on a leadership course because obviously I can't hack it. I'm not capable, I'm incompetent, so I need leadership skills. I don't fucking need leadership. I am a born leader. That's what I was good at. That's where I am. And I've now learned to own that space and challenge appropriately. So I think if we continue to challenge, but we need to have some open, honest dialogues about this and a fundamental rethink about the NHS. I believe in it. I trained in India. I lived in India till I was 28, and I came to the UK and made it my home because I believe in the NHS. I still do, and it's so fundamentally broken. But we need passionate people like yourself. We need the lived experience, and we need more optimistic people to keep it going. It's not something I'm good at. I'm very good at some of the things that I do, but I just don't see it surviving, not in its present form. Sorry.
Would I also be able to just add something, that I also think that there's like a level to which I think there's so many people that slip through the gaps, and that the whole that the entire system at play in terms of society has a responsibility and a role within the wider picture of how to pick people up sooner. You see it within schools. I know I saw it within my own educational environment, how both myself and other people around me, you could see that inevitably there were going to be issues and problems further down the line. And I imagine that not everybody there will have been eventually presented in front of a primary care provider or whoever, but that there will have been a good chunk of those people who did go with, thanks to parents who were on it, or because of maybe themselves or a teacher or whoever. And I think that it is the duty of like society as a whole, but also that those warning signs are there and present within all of those things, and it's about avoiding people falling through those cracks. I think there is a natural inclination in educational and healthcare settings to kind of assume that it's only worst case scenarios that become worst case scenarios almost, but that actually there's loads of children who wouldn't necessarily be alarm bells in those things, but that they're there, I think, essentially. I know that doesn't necessarily completely answer it, it's just my 2 pence in terms of what I know I felt, and I felt then later on down the line, having presented myself so frequently, incredibly disillusioned with, you know, with the idea that there was accessible help, and that ongoing frustration, I imagine for some people, worsens it significantly, especially I think a lot for young men as well, where it takes probably a little bit more to have to present yourself and expose vulnerability, and that anger can really develop. So yeah, just my thoughts on it.
No, I think the NHS is so problem oriented. Because I trained in a different healthcare system, I was amazed when I started training here how you can only get help if you kick up a fuss. You can be as disturbed as you can be. You can be extremely depressed. You could be extremely anxious, but until you act out, you don't get that amazing package of care that you guys are providing. You know, you have to be suicidal, you have to be homicidal, you have to be psychotic, you've got to be aggressive, you've got to be not in education.
And then they can find £1.2 million within 24 hours.
Yeah, and it's
for like
just,
a whole year's
you know,
care.
why?
Yeah.
So I think I love your idea of solution focus, but the problem is the NHS is so oriented. You know, you go in and you see your GP, what's the first thing they say? What's the problem?
So where does it
We need a
start?
cultural shift.
So it starts with what this lady's very, very rightly
Early
said,
intervention.
doesn't it? It starts with early intervention, it starts with picking people up early and providing the right intervention at the right time. Because if everybody got, you know, I'm just talking about bipolar because obviously that's what we're talking about today. But if everyone got diagnosed, you know, early on when they start having symptoms and people were trained and they knew what they were looking for, and then they got a package of care where they maybe got their medication sorted and they got psychological therapy so they could self-manage and they could ask earlier for help if things weren't going so well, then actually they wouldn't go backwards and forwards in inpatients or expensive treatment or ending up in pathways like yours. And so I think that's where we have to do. But at the current time, everyone is focused on let's put more, inpatient care is really expensive, let's try and put more money in crisis teams. No, let's try and stop people getting into the crisis in the first place.
I
think we're all
disagree that the NHS don't have money. They have a lot of money, they just don't spend it properly.
There's so much wastage in the NHS. No, there is. Sorry, anyway.
I just wanted to add to that in terms of the neurodivergence aspect and picking up people. I think what we often observe is that when we're dealing with young people at younger ages, it's they don't necessarily meet threshold for a particular diagnosis, or they're not meeting threshold for a mental health illness at that point in time, so they're not getting picked up. And so then they fall into the more social care sector, or that, as Eva said, you know, in education, they might be presenting with difficulties in education, but the people in those services aren't trained or don't have the knowledge to be able to identify what those needs are at that early point in time. And I think there's a big piece of work, and I say, you know, within within education we have EHCPs, and it's meant to be the bringing of services together, but in reality that doesn't happen. And I actually think that there's a massive piece of work in being able to work together and to really upskill all the services to understand what the needs are of young people at that point in time, and that we're not just coming from a diagnostic lens and a problem-focused lens and picking up people earlier before they meet threshold. And that's the point of early intervention, and I don't think we have the services at this point in time really coming together to be able to do that.
Can I just throw sixpence in? We find, it's touching on the early intervention, you know, we find the feedback that we get is having something as basic as what we're offering for the price of a school photocopier can make a huge difference, in that children will be able to attend school that would be self-absenting because they know that they have the safety net, you know, when they're feeling uncomfortable, especially as they get older. You know, as teenagers present, you know, their biggest fear often can be that they're going to have a meltdown that they can't control in front of their peers. So, all teenagers, have their own personal anxieties, but just to throw in some positivity, we would find that money is the big issue that we encounter all the time, and unlike everyone here, I'm coming from the commercial world. But one of the things that we have found has worked quite well is that if institutions, be it schools, be it care institutions, access the commercial world if they're not getting listened to. Because we find that everyone wants what we've got. When the penny drops of what offers, everyone says, yeah, I'd love it, but, and there's the but. One of the things that has worked very successfully is that, and this all happened just by some savvy people, they showed us the way. They said, forget this, they don't have the time to wait for funding, because they could be 5 years or whatever, and the need for the people in front of them has passed. And they've gone through the corporate social responsibility route. And the interesting thing about that is that at the stroke of a pen, they can get some of these things funded. So we would find that maybe as many as 1 in 10% of the units that we supply are funded wholly or partially by corporate social responsibility. And just to finish up on that topic, businesses are looking for their own reasons. Some of it is altruistic, some of it is commercial, that they're looking for something that will reflect well on them and their brand. So they go and fund something like that, and they get a ribbon cut, put it up on their website, etc., etc. And it works very well, and it works very quickly, because we had a situation in one school where we mentioned this because it's been successful, and this school said, look, this isn't going to happen. Most of the people here don't own businesses, so they're not going to be able to fund it. But a week later, the principal came back and said, we got one. Because a guy in the warehouse went to his boss, said, would you be interested in funding this? And they did. Because they will get the VAT refunded straight away, and then they can, as a charitable contribution, they can save money that way. So I'm just saying, sometimes it can seem very bleak, but if you're savvy, there are ways around it. And like we had one person, they were, a parent was involved, they were a member of the local, I can't remember, with Rotary or Lions Club. They went to the Lions Club and they pitched this, and the Lions Club, my God, this is cool. Because they said half of the time we're getting rid of graffiti, because Lions Club and Rotary Clubs, their only function is make a difference in their community. So these things could apply to anything. And this was pitched to them, and they said, look, we're getting rid of weeds, graffiti, putting flowers in roundabouts. These are the type of things that we're doing. They looked at this and they said, my God, this is children disability education. What a difference it can make. And it just resonated with what everyone says here, especially with children. You can make a real difference early on, and that Lions Club funded for. Because they said, look, we couldn't find a better home for the money that we looked at. So I'm just saying there are other ways around the walls and hurdles that are put in front of you all the time.
Yeah, I think we're about to, hopefully, touch wood, run a big public awareness campaign around bipolar, and there'll be stuff on social media nationally, but also targeting a specific geographic location, and that will cost hundreds of thousands, but it's all through private donations. But we know there's about 6 million people affected by bipolar in the UK. If they all gave £1, which is not a lot of money, we could provide universal peer support, have a group in every community, and offer self-management courses pretty much to everyone who gets a diagnosis. Obviously, it'd be nice if the NHS could help with that as well. But it's, I think we can do, you eat the elephant one bit at a time, don't you? And also, just to reassure Addy, I think the psychiatrists have a £2,000 a year budget for CPD. All of you who are psychiatrists can obviously get your CPD credits as well from today. So those budgets update every year. There's no reason why, if you're a clinical psychiatrist, you shouldn't be doing bipolar at least once every couple of years as part of that. And then someone presents to you and you can get them a diagnosis quicker, then you've helped that person's life, and that person will end up require less future care. So it could be a win-win all round.
Can I make a comment?
Go on.
I made a comment about resources and how resources are used. I think one of the big issues that we have in the NHS for several decades is that each Secretary of State that comes in with brilliant ideas, and we continue changing the NHS. We move the chairs around. There is money here, but money is being used in a way in which, as some people have said, if you have the voice to make it heard, and if you behave badly, you get attention. And to address that problem, money is episodically put in that area. We now have integrated care. I wondered whether integrated care will make any difference. Wes Streeting came in and said the NHS is collapsing, which I thought was a rather strange comment to be made, whilst people are there in the NHS busting their guts to perform a service. So essentially, those of us who advocate for the change should say, stop changing the NHS each Secretary of State. There have been 42 Secretary of State since 1970, and they keep changing them again. So I think essentially there's money there, but the advocacy must be how the money could be spent, and whether within integrated care it will make the walls, it will help the walls to collapse. And this is where those of us who are concerned about how the money is allocated should really be pressing for that. So that's my comment.
You're advocating for consistency of funding and the running of the budgets in the same way as we're advocating for consistency of care for the service users. It needs to be...
The CCG was closer to the population. The Integrated Care Board and the Integrated Care Partnership you've got to go through more hoops. So the voice lessens as it gets higher up, and the strategy of what you're trying to advocate is lost because the champions are in a different structure. So I mean, this is what is happening. We could integrated care. We're now saying that the resources in integrated care are not being managed properly in two health boards, integrated boards across the country. So, we keep reinventing the wheel all the time, but, we're going around in circles. I think
There's an advantage to reinventing the wheel, because you can never compare apples and pears. That is, I'm sorry to be so cynical, but if we compare our healthcare system with the American healthcare system, you're right. They don't change their healthcare system as regularly, in such a manner. But every Secretary of State wants to leave their mark, and that's the danger. I think health should be divorced from politics. That's what I fundamentally feel, and let in charge of people that are capable and competent and have a longer, medium to long-term plan. Because this, I really hope the NHS survives, despite my doomsday. I agree with you. I think we just need somebody who's visionary, who carries that forward and doesn't always change things around, because it impacts on morale of staff. We're all tired and exhausted.
Wasn't that what the Landsey reforms were supposed to do? NHS England are supposed to do the day-to-day commissioning, aren't they? And the politicians are not supposed to intervene.
NHS England doesn't commission anything now.
But
it's all devolved to ICBs. NHS England doesn't commission a single service.
Andrew Lansley, his brilliant suggestion of changing the NHS was gradually being eaten away by Simon Stevens' structure. The 10 years review was actually chipping away at all the things that Lansley was putting in. So we keep messing around with the structure. Sorry.
No, it's a fair point.
So the gentleman there in the back, waiting very patiently in the grey shirt.
Sorry, I didn't say. Sorry, go on.
So this is a bit of a different direction, but
So we're doing a lot of stuff with digital. It's proven almost impossible to get it funded. One of the things that we've been doing since 2015 is kids, we use these, and Lizzie uses them as well, we use mood monitoring diaries. They're horrible paper and pen. You wait, you fill them up for maybe 3 months before you see a psychiatrist again, and then it takes another 2 weeks to get feedback. If you're a teenager and you've got a mood disorder, you can't wait that long, to kind of positively reinforce the need for that. But the young people came up with this idea. That was my first introduction to co-design and co-production, and I loved it. They said, if you had an app, and we said, that's nonsense, vibes have been of England and all that kind of stuff. But eventually I got so fed up that we asked them to open their iPhone, and I said, just put in the notes section, put the date, put the score on a scale of 1 to 10, and send us your mood diaries. And they started to send those to us. Our response rates doubled. Now bear in mind that there is nothing beyond us in the UK. So we did that. We then applied for some primary funding. We got that. We've actually published 2 papers on this, and everybody says it's fantastic, but nobody will give us the funding to take it from this is a proven thing which has been peer-reviewed and published in reliable journals to make it fully viable. We've spoken to everybody, but they say, yeah, if you can get it done, then we give you funding to evaluate its effectiveness. I think digital has huge promise, especially in mood disorders. It can, yes, there are some active things that you can put in, such as your mood scores, etc. You can make notes of what things worked and what didn't work, but we can also collect so much data passively. Sleep, for example, just through your smartphone. You don't even need a Fitbit or an Apple Watch or something. It's more reliable, but plus minus 30 minutes, we can get data on that. We can also, with consent, look at your use of social media monitoring, and that can be used in algorithms to show early signs of relapse. The potential is endless in the field of mood disorders and anxiety. We just need somebody to invest in it and allow us to then monitor. But the other thing that I would say is it doesn't work for everybody. So there's this belief that digital is going to revolutionize the NHS. It will, absolutely. But what we need to know is who it works for. And when we think about personalized, individualized care, we need to be able to push the right technology at the right person at the right time. So that's where the evidence has to be taken. But we can't do that until the technologies are funded, and then they are evaluated, and then we look at who it works for. But I completely I'm sold on digital. We haven't given up, and we're doing a lot of work looking at doing exactly this kind of work with young people. And when I say young people, I'm talking about up to 25 or 30, because that's where they're sort of born with that, as it were. So there's huge potential.
I think there's potential for savings as well, because it's revolutionised the way that we offer therapy across Birmingham. Before, there was huge waiting lists in different areas. In Solihull, because there's a smaller population, you get your therapy quicker than if you're in North Birmingham. But now it's all one group. People actually are opting more for the online therapy than they are for the face-to-face therapy. And we have developed, it's a different art in terms of teaching therapists how to deliver a group online. It's not easy, and we've had to have a massive papers to try and get Zoom, because Zoom has got some functions like I can chat to my co-therapist if someone's not looking very good in the group, and they can go off into a breakout room and check on them. So I know it's not new technology, but utilising technology that's very straightforward, like Zoom in healthcare. If I don't have 3 psychological therapists in one area, I can share psychological therapists. I could have one in Northumberland, I could have one in Wales, and I could have one in Cornwall, and we could run one group, and we could have service users from all over. So, there's different ways that you can utilise technology and platforms in particular to mean that you can expand the therapies to places you couldn't get it before, like rural areas. And I think for groups of people who are uncomfortable attending, like I said, health buildings, things like that, that you can tap into communities that perhaps wouldn't have come before, and support people with different inclusion needs like work. I mean, for me, it'd be really hard for me to attend regular 1-hour appointments every week in my current role. But if I could just log on, in fact I did log on because one of my children's got healthcare needs, and I joined a parent group for once a week for 3 weeks, and that was really easy to do, and that was run from Bath. So I think it really can help spread the interventions that we do much wider and make better use of our current human resources that we've got. I know it's boring because it's not a gadget.
Is that, is that giving you confidence in the future then?
Yeah, definitely. But it also kind of highlights how there's an awful lot of stuff out there that's been plenty good for 8 years. We just have to bring it into our practice, and it's hard finding that space. That money can be time, or it can be, skill mixing or whatever, to actually bring it through into practice.
But also I think there needs to be partnerships between clinicians and people with the tech, because you do have to teach people to work in a slightly different way if they're utilising that kind of environment.
And tech has to, any tech, whether that's a platform or a gadget or whatever, I think it's fundamental that it's co-designed and co-produced. And a lot of this is done in silos with, a tech person, possibly a clinician, but there's no involvement with the other people, with patients or families. And I think it's really important. And just because something works with an adult doesn't mean it'll work with an adolescent, or indeed it'll work with somebody who's 65 plus. So, there will have to be developmental modifications as well. But totally up for it. I think, we must. I was on a trip to India at the National Institute of Mental Health there. We were running a workshop. We had some funding to run a workshop on digital needs for India. I came away thinking, we need India more than they need us. They already run something called the Primary Care Psychiatry Program, where they have people in primary care physicians, GPs, in rural areas with high-speed Zoom. They have an on-call consultant and registrar in psychiatry available 9 to 5 for any of those primary care physicians to dial in with the patient live in the room to do the assessment, and they're given a diagnosis and a plan. This doesn't happen in the NHS. We could make it happen. What's the problem? We're going to actually write a piece about this for the British Journal of Psychiatry and say the lessons the UK can learn from India.
Absolutely.
We really shouldn't be naive thinking we know it best, because we don't.
No, it's a lot we could learn, for sure. We've got 5 minutes left. One last question. Or we can go. It's fine. Camilla, you going to ask a question? No, she wasn't. She's saying 2 minutes left. Nobody outside.
Everyone's gone.
Brilliant. We can all go home then. Thank you very much. Let's end on a moment of hope. We can eat the elephant one little bit at a time. And we've talked about lots of things that can be done to improve care for people with autism, but also obviously people with bipolar. And these small interventions that don't cost a lot of money can do a lot to that person's life, and also to keep them out of hospital and to save the NHS a lot of money. So I think we can all go home thinking that we can fix this problem, and perhaps have a coffee and maybe a beer as well, or whatever people say for us. Thank you everybody for persevering.